Hello and welcome back to the Deep Dive, where we take complex topics and, well, we dive deep. Today we're navigating the incredible world of organ transplantation. Specifically, we're looking at one of the most critical, high-stakes moments, how doctors decide if a donor liver is truly viable for transplants. It's a decision that literally impacts whether someone gets that second chance at life. We've been given a stack of fascinating sources on this, from cutting-edge research to clinical guidelines. And our mission today is to extract the most important nuggets of knowledge for you. We're going to explore a remarkable new technology called Normothermic machine perfusion, or NMP. It's fundamentally changing how these decisions are made. So our central question today is, how do transplant teams decide if a donor liver, particularly one that might be considered marginal or extended criteria, is truly ready for its new home? What are the critical warning lights, the red flags they're looking for?
That is an incredibly important question. And what's really fascinating here is that NMP, it's essentially like giving a donor liver a thorough test drive outside the body.
A test drive, okay.
Yeah, instead of just, assessing it while it's sitting in static cold storage, NMP simulates near physiological conditions. It perfuses the organ with warm, oxygenated blood-like fluid. And this lets teams see how a liver actually performs in real time. They get to observe its function before it ever reaches a recipient.
So you can actually see if it's working properly before the surgery.
Exactly. And those red flags we mentioned, they're crucial. They're warning indicators that a liver isn't tolerating this perfusion, or maybe it's not functioning adequately. It signals it might be unsafe to transplant. Identifying these helps avoid really serious issues for the patient, like primary non-function PNF, where the new liver just doesn't work at all.
Right, the worst case scenario.
Or even just early dysfunction. We broadly categorize these red flags into biochemical signs, hemodynamic ones related to blood flow visual cues, and even histological, looking at the tissue itself. But, and this is vital to understand, viability isn't a simple yes or no. It's the likelihood of the liver functioning well post-transplant. And no single parameter is perfect. Teams always use a combination of criteria, interpreting all these warning signs together in context.
Okay, so if NMP is our test drive, let's start with the engine diagnostics. What are the first biochemical signs, the sort of blood tests of the perfused liver that tell us something might be wrong? You mentioned lactate clearance.
You're absolutely right. Lactate is a primary signal. So in a healthy liver during NMP, lactate levels typically rise initially. That usually happens in the first 30 to 60 minutes.
Why is that?
It's mostly anaerobic byproducts washing out from the cold storage period. But then the key is they should drop steadily as the liver gets back to normal function. It actively uses that lactate for gluconeogenesis.
Making glucose, right, for energy.
Exactly, converting it back into glucose. So by a couple of hours, maybe 2 or 3, a viable liver's perfusate lactate should be low, almost normal, and ideally stay that way.
So the red flag is if it doesn't drop.
That's the major one, the failure to significantly reduce lactate. If levels stay persistently high, let's say, above maybe 2.5 mmol after 2 or 3 hours, or if they can't get below 2.0 mmol by hour 4, that's a serious concern. And what's even more worrisome is a rebound rise.
It goes down and comes back up.
Precisely. If it drops, then climbs back up towards 4 millimolo or even higher. That indicates poor hepatocellular function, poor energy production, basically. The liver's metabolic engine is just struggling. An inability to clear lactate remains one of the clearest warning signs during NMP, though, again, it's never interpreted totally in isolation.
Makes sense. What about pH? Does the liver's activity affect the acidity of the perfusate? Like, is the environment getting too acidic for the liver to work properly?
Exactly. A functioning liver helps maintain a neutral to slightly alkaline pH. It does this by consuming those anaerobic byproducts like lactic acid and generating bicarbonate. So some metabolic acidosis during NMP, where the pH drifts below, say 7.2 or 7.3, that's definitely a red flag.
And how do they manage that during perfusion?
Well, they can add bicarbonate to the perfusate. But if the liver needs unusually large amounts of bicarbonate supplementation, for example, needing more than maybe 30 millinol total bicarbonate administered over the perfusion just to keep the pH stable.
That's a bad sign in itself.
It's a very serious indicator. It points to ongoing anaerobic metabolism and severe liver dysfunction. And it often goes hand in hand with those high lactate levels, showing a kind of broader metabolic crisis in the organ.
Okay. Now, I know about ALT and AST from regular blood tests, liver enzymes. What do those tell us when the liver is being perfused outside the body on NMP?
Right, ALT and AST are enzymes that leak out when liver cells, the hepatocytes, are injured or dying. Some initial release is expected, kind of a washout from the stress of retrieval and storage.
Okay, so a little bit is normal.
A little bit, yes. But a sharp upward trajectory or a steep, continuous climb in ALT or AST beyond the first couple of hours, say 2 to 3 hours in, that's alarming. It signals ongoing cell destruction, hepatocellular death. That likely points towards primary non-function if it were transplanted.
Are there specific numbers they look for?
Extremely high peaks are particularly concerning. Imagine ALT levels soaring well into the thousands, maybe over 6,000 IUL, or AST climbing above 1,000, 1,500 IUL. Also, a sudden surge like the levels doubling or tripling within just an hour during the perfusion, that's definitely a trigger to potentially stop and say, this isn't safe. And generally, ALT is considered a bit more specific to liver injury than AST. AST can sometimes be affected by other things, like red blood cell breakdown in the perfusion circuit,
Ah, okay. Good distinction. And what about glucose? Is the liver's ability to handle sugar another sign of viability?
Absolutely. A viable liver should show the glucose levels in the perfusate dropping over time. It takes up glucose to use and to restore its glycogen stores.
So storing energy for later.
Right, so a red flag here would be persistently high or even rising glucose levels, or if the liver fails to significantly lower the perfusate glucose after they give it a glucose challenge, basically a bolus of glucose to see how it responds. It indicates the liver isn't performing its normal anabolic functions, building things up. It suggests hepatocyte injury or maybe just exhaustion. Another sign the engine isn't processing its fuel correctly.
So stepping back from these individual tests, how do these biochemical markers work together? What's the big picture they're painting?
Well, they often interrelate, don't they? They paint this powerful picture of an organ in distress. A liver failing to clear lactate will very often develop acidosis and show significant enzyme leakage from dying cells. What's truly remarkable here isn't just that these markers exist, but how they often converge. They tell this singular, urgent story. The liver is in an energy crisis. It's struggling to fuel itself, struggling to rebuild. And without that fundamental power, its chances of working long-term are, frankly, severely compromised.
That's a really clear way to put it. An energy crisis. Okay, so that's the liver's internal chemistry. But you need good fuel lines too, right? How does NMP let us assess the liver's plumbing, its blood flow, the vascular system?
That's a great analogy. NMP continuously monitors blood flow rates and also the vascular resistance in both the hepatic artery and the portal vein. Those are the two main vessels supplying the liver.
Okay.
So a red flag for low flow would be markedly reduced flow rates, even when they're maintaining normal target pressures in the machine. For an average adult liver, say 1.5 kilograms, a hepatic artery flow below about 150 millimin, or a portal vein flow below maybe 500 millimin, those are ominously low numbers.
And what does that low flow suggest?
It can mean several things: narrowed or blocked blood vessels, maybe spasm, thrombosis clots, or just severe endothelial dysfunction, meaning the lining of the vessels isn't working right. The liver's metabolic needs, especially for the bile ducts, really depend heavily on adequate hepatic artery flow.
So if the blood isn't flowing well, does that mean there's high resistance? Like trying to push water through a clogged pipe?
Exactly. High resistance, or resistance that actually climbs higher over the course of the perfusion in either the hepatic artery or the portal vein circuit. That's another critical red flag.
What causes that?
It often happens because of ischemia reperfusion injury, IRI. That's the damage that occurs when blood flow returns after it's been cut off, like during cold storage. It can cause swelling or tiny clots, microthrombosis, that narrow the capillaries inside the liver. It basically suggests the microcirculation, the tiny blood vessels, aren't opening up properly. The liver's really struggling to recover from that ischemic hit.
And what about how the liver's vessels respond? Can you test if they behave like healthy vessels should?
Ideally, yes. We can test their responsiveness, for example, by giving vasodilator drugs to see if the vessels relax and open up, lowering resistance. So a red flag is when the liver's vasculature seems fixed, it just doesn't respond to these agents. Or if the perfusion pressures are unstable, sudden drops, or pressures that just skyrocket unexpectedly.
Unpredictable.
Very unpredictable. It suggests severe endothelial dysfunction and makes for an unreliable graft. Normal, healthy perfusion should be hemodynamically steady, like a well-regulated system.
And can NMP help spot if maybe only parts of the liver are getting good blood flow, like a patchiness?
Indeed it can. Uneven perfusion is a critical visual red flag during NMP. You might see parts of the liver that stay cold or pale, while other areas look warm and red.
So you can actually see the difference.
You can literally see it. This could mean there's a thrombosed vessel branch supplying that area, or maybe an anatomical variation. If transplanted, that could lead to partial graft necrosis, part of the liver dying off. Homogeneous perfusion, getting good flow everywhere, is so important that some viability criteria actually list it as a specific requirement. And it's worth remembering, especially if we talk about smaller grafts later, these parameters are often normalized to liver size. Flow per 100 grams of liver tissue is really the key measure there.
Okay, internal chemistry checked, blood flow dynamics checked, but the liver does something pretty unique, right? It makes bile. That feels like a signature function. Does NMP let us watch that? What are the red flags related to bile production?
Absolutely. Bile formation is a really high-level indicator because it requires significant energy and healthy, functional cells. It's a complex process. So a major red flag is simply no bile production. Absolutely zero bile produced after, say, 3 or 4 hours of perfusion, or even just very scant output, maybe less than 2 milliliter total in 3 hours.
That little, wow.
Yes. It implies severe impairment of the liver's synthetic and excretory functions. It correlates strongly with poor energy levels within the liver cells. By and large, no bile often means no transplant. It's a pretty strong signal.
Incredible. Can you tell anything just by looking at the bile? Its color or consistency?
Visually, yes, definitely. Healthy bile is typically a golden yellow to a kind of green-brown color. And ideally, it becomes more concentrated, maybe darker over time as the liver works. So red flags in appearance would include bile that stays persistently clear or watery, looking almost like the perfusate fluid itself. That suggests the liver isn't actively secreting the bile components. Or dark brown or black bile can suggest blood or hemorrhagic injury, meaning maybe the bile duct lining is compromised. And thick, sludgy, tarry bile with debris points towards cholestasis or maybe sloughing cells, another warning that the biliary tree isn't healthy. Surgeons actually find seeing that gradual darkening of the bile quite reassuring, shows active secretion.
You mentioned the biliary tree, the bile ducts. And you touched on the cells lining them, the cholangiocytes, earlier.
Yeah.
Do they offer their own specific clues about viability separate from the main liver cells?
This is critical, yes, and it's a growing area of consensus in the field. Cholangiocytes, the cells lining those bile ducts, actively modify the bile. They're quite metabolically active, and they are highly vulnerable to ischemia or reperfusion injury, sometimes even more vulnerable than the main liver cells, the hepatocytes.
So what are the warning signs from them?
Well, a key one is biliary pH, bile that remains acidic that never becomes alkaline, say. It stays below a pH of 7.4 throughout the perfusion. That's a big red flag.
What does it indicate?
It points strongly towards cholangiocyte dysfunction. And importantly, it's been shown to predict ischemic cholangiopathy, serious bile duct complications after the transplant. Studies have directly linked that low bile pH during NMP to later strictures.
Oh, wow. Okay. What else?
Another indicator is biliary bicarbonate. If the bile bicarbonate concentration is low, especially if it's not much higher than the bicarbonate level in the perfusate fluid.
It means the cells aren't adding bicarbonate like they should.
Exactly. They aren't secreting bicarbonate properly, suggesting injury. And finally, there's the ratio of glucose in the bile compared to the perfusate. High bile glucose or a bile to perfusate glucose ratio greater than about 0.67, meaning the glucose level in the bile is getting close to the level in the perfusate. That's a significant red flag.
Why is that?
It means the cholangiocytes are not reabsorbing glucose from the bile back into the bloodstream as they should. This indicates bile duct epithelial loss or damage. And this marker specifically predicts later non-anastomotic biliary strictures, a really difficult complication. And what's so crucial here, I think, is that a liver could ostensibly look okay on some metrics.
Right.
Maybe it clears lactate all right, transaminases aren't terrible, but it could still have badly damaged bile ducts.
So you need to look specifically at these biomarkers.
You really do. It makes these cholangiocyte markers equally important for assessing a truly viable graft. They're a somewhat newer focus, but an increasingly vital set of warning lights on the dashboard.
So we've got the internal diagnostics, the plumbing, the specialized outputs like bile. But sometimes the simplest observations are key. What can the surgical team literally see and feel about the liver during NMP that signals trouble?
Right. Direct observation is continuous, and sometimes the most obvious signs are right there in front of you. A red flag for color and homogeneity, how uniform it looks, would be patchy discoloration, mottling, maybe pale or blanched areas, or even deep purple or blackish spots.
Suggesting poor blood flow in those areas.
Exactly. Or maybe congestion or just poor oxygenation. An overall dusky or cyanotic appearance is also concerning. An organ that fails to pink up to a healthy ruddy tone, or worse, reverts to a poorer color during perfusion. That's a very bad sign.
What about the feel of it? Turgor.
Yes, turgor and edema. A liver that becomes very firm, really distended, or noticeably heavy with fluid that suggests vascular injury. Fluid is leaking out of the vessels into the tissues. This could indicate severe ischemic injury. Essentially, the liver is swelling up with distress.
And fat. You see if a liver's too fatty?
You can visually severe steatosis. That's a very yellowish, greasy, often enlarged appearance because of excess fat. That's another clear red flag. Sometimes if the perfusate fluid itself starts to look milky or you see oily droplets floating in it, that's a big clue.
Why is fat such a problem?
Well, fatty livers tend to have poor microcirculation. Those tiny vessels don't work as well. And they're generally at higher risk of failure after transplant. If they suspect macrosteatosis, the more dangerous kind of fat is over, say, 60% just by looking. That's often a reason to decline the organ. And then, of course, there are other visible abnormalities. A nodular hard liver surface that suggests cirrhosis or significant fibrosis, or finding unexpected tumor nodules during inspection, or even just significant uncontrollable oozing from hematomas or cut surfaces. Even a subjective bad feeling about the organ's look and feel, while hard to quantify, can contribute. It can lead a surgical team to be more conservative and decline it. It really is the cumulative picture.
It's fascinating that the simple look and feel still plays such a critical role alongside all the high-tech measurements. Now, if we go even deeper, microscopically, can a biopsy taken during NMP reveal critical issues the other tests might miss, like a hidden structural flaw?
Yes, histology looking at the tissue under a microscope can definitely uncover structural injuries that aren't immediately obvious from the perfusion numbers or even the visual inspection. For instance, beyond just seeing if cells are dead, histology can reveal critical silent issues like microvascular and endothelial injury.
What would that look like?
You might see disruption or loss of the sinusoidal endothelial lining. That's the delicate lining of the liver's smallest blood channels. Or you might see microthromby, tiny clots forming in those small vessels, or widespread fibrin deposition. These are definite red flags because they tell you the liver's intricate blood network is compromised. Flow will be impeded even if the NMT machine is trying its best to push fluid through. It's structural damage you just can't see otherwise.
What about the main liver cells, the hepatocytes?
Well, widespread hepatocyte necrosis cell death is obviously a major red flag, especially if it's extensive, say over 30–50% of the liver tissue, or if it's confluent, meaning large areas are dead. Progressive necrosis, where biopsies show more cells dying over the course of the perfusion, is also very worrying. For DCD livers, donation after circulatory death livers, which have suffered more warm ischemia, even seeing more than maybe 20% necrosis is particularly concerning. It indicates very limited functional reserve and a high risk of PNF.
And the bile ducts, again. Can histology confirm problems there?
Absolutely. Seeing cholangiocyte necrosis or thrombosis in the tiny blood vessels surrounding the bile ducts, the parabiliary plexus, or seeing the lining epithelium sloughing off in bile duct biopsies, these are clear histological red flags. They indicate non-viable bile ducts, strongly predicting ischemic cholangiopathy later on, and they really validate those biochemical bile findings like low pH or high glucose we talked about. Now, routine histology isn't always done in real time during every NMP because of the time it takes to process. But if a biopsy is done and an overt histological catastrophe is identified, that's a red flag that's very hard to ignore.
Okay, so we have this whole suite of indicators: biochemical, hemodynamic, biocharacteristics, visual signs, histology. What does this all mean for the rule book? Are there clear, established cutoffs or specific criteria that transplant teams use to make these incredibly difficult decisions?
That really hits on the crucial question of standardization. Over the past decade, as NMP has become more widespread, various viability criteria have been proposed. They try to combine these parameters with specific thresholds. So for example, broadly speaking, many centers would look for lactate to clear significantly, maybe dropping below 2.5 mmol, perhaps even 2.0 within 2 to 3 hours.
Okay.
Perfusate pH needs to stay stable above, say, 7.3, generally requiring minimal bicarbonate, maybe less than 30 millimol total. ALT and AST shouldn't show that continuous sharp rise after the initial washout. Peaks ideally need to remain below certain levels, like maybe 5,000, 6,000 IUL for ALT.
And the flow?
Flows need to be adequate for the liver size. For that typical adult liver, hepatic artery flow generally needs to be over 150 millilem, portal vein flow over 500 millilem, roughly. Bile production must be present, definitely not zero. Some criteria might specify, say, more than 2 millicalo total within 3 hours, or maybe more than 10 millimello by 2.5 hours. And critically, that biliary pH must become alkaline, getting above 7.4, maybe towards 7.5. And the bile glucose needs to be substantially lower than the perfusate glucose, with that bile-to-perfusate ratio staying below 0.67.
So hitting multiple targets.
Yes, and then biopsy results, if available, should ideally show hepatocyte necrosis below around 30%, and, importantly, intact cholangiocytes. Now, broadly, the literature agrees on the importance of all these parameters, but the precise cutoffs, they can still vary a bit between different transplant centers. It reflects evolving evidence and maybe local experience, too. What's clear is the move towards a multi-parameter approach. The UK Viable trial, for example, was influential. It required multiple criteria, lactate, pH, bile production flows, glucose metabolism, to all be met for a liver to be deemed transplantable.
So it's rarely just one thing.
Rarely. While a single red flag, if it's extremely pronounced, like absolutely zero bile production for hours, might be enough on its own to decline an organ, more often it's a combination of persistent red flags that leads to that difficult decision. And it's worth highlighting that evolution, again, those bile duct viability markers like pH and glucose, they're now increasingly recognized as just as crucial as the markers for the main liver cells. That realization came after some earlier experiences where focusing only on hepatocyte function sometimes led to unexpected biliary complications down the line for patients.
That makes a lot of sense. Now, this is all fascinating for adult livers, but what happens when we're talking about transplanting a pediatric liver? Are the red flags different for a much smaller, maybe younger organ, or is it just about scaling everything down?
Well, what's interesting here is that while the fundamental red flags, the types of problems remain the same, the context definitely changes quite a bit. Scaling is certainly part of it. Absolute values for things like flow must be interpreted on a per gram or size-adjusted basis, milliliters per minute per gram of liver tissue. Qualitatively, though, the red flags mean the same thing. If a tiny graft's lactate doesn't drop, that's still a red flag.
Are smaller livers more resilient or more fragile?
It can be a bit of both. Pediatric livers from very young donors are often inherently healthier and might recover faster, which is obviously a positive. However, small livers also introduce unique technical challenges for the NMP procedure itself.
Like what?
Well, things like designing the circuit to prevent too much heat loss from the small organ, or ensuring the prime volume, the amount of fluid needed to fill the machine, doesn't kind of overwhelm or dilute things too much for the tiny organ. NMP is actually proving particularly useful for split or reduced size grafts, which are often used in children. It lets the team check that each segment they've created is viable before transplanting it. A significant difference in perfusion or function between segments would be a major red flag in that scenario.
Is there as much data for kids?
That's a key point. The literature on pediatric NMP is still much sparser than for adults. Protocols are actively being developed and refined. So it often means a more cautious approach is taken, frequently extrapolating from adult criteria while research catches up. And arguably, because pediatric recipients are so vulnerable and the long-term consequences of complications are so significant, the threshold for deeming a liver viable enough might actually be even higher. Stricter, you could say.
So even a small hint of a problem might be enough to say no.
Potentially. A hint of a cholangiocyte issue from the bile analysis, for example, might lead a team to discard an otherwise acceptable-looking liver for a child, just given how devastating ischemic cholangiopathy can be long-term. The stakes just feel incredibly high.
This whole deep dive really highlights how this advanced science and just meticulous, careful observation have to come together for these critical, life-saving decisions. It's clearly not just about a single number or a quick look, is it?
Exactly right. NMP has given transplant teams this incredible test drive capability. It takes away a lot of the guesswork. And when multiple red flags pop up persistently and in combination, say you have a liver that just never clears its lactate, produces no bile or only acidic bile, and has skyrocketing AST levels, well, the decision, while difficult, becomes much clearer.
Prioritize safety.
Prioritize patient safety, absolutely. And it's worth mentioning, NMP also offers the potential ability to rehabilitate some marginal grafts during perfusion, maybe flush out toxins or deliver treatments. But if those interventions don't correct the red flags, they serve as a pretty clear stop signal. It's about using this amazing technology to make the most informed, safest decision possible.
So wrapping this up, what does this all mean for us, for the listener? What's the biggest takeaway from digging into all these complex indicators and red flags?
I think the overarching goal, the big takeaway, is that all this effort is laser focused on ensuring that only livers with a really high likelihood of success actually get transplanted. It's about improving patient outcomes, maximizing the benefit of this precious gift of donation, and avoiding those catastrophic early graft failures. Just as you wouldn't ignore the oil pressure light flashing on your car's dashboard and drive off, modern transplant practice, enhanced by NOP, teaches us not to transplant a liver that's showing these equivalent warning lights of impending failure.
That's a great analogy.
And maybe the provocative thought to leave with is this. The real game changer ahead might not just be getting better at identifying these red flags, but perhaps using NMP more actively to correct some of them, to push the boundaries of what constitutes a viable liver, and maybe even tailoring that whole viability assessment not just to the organ, but also to the specific condition and needs of the person waiting for it.
A powerful and hopeful thought to leave us with indeed. Thank you so much for sharing your expertise on this deep dive into the fascinating world of liver transplantation and its life-saving red flags. And thanks to all of you for joining us. Until next time, keep learning, keep questioning, and keep diving deep.